Hi guys, can you see and hear me? Yeah. Hi guys, can you see and hear me? Okay, first of all, apologies. Very sorry for the mild delay. So we had a little bit of technical issues, which is actually a fault from my side. Number one. Second, I started a bit late because today is a Saturday, and I was little held up with my practice. Generally, Saturdays we used to have a little bit of more patients. So unfortunately, there are like 5 to 6 patients who got added up at the end, like around 8:30. So that's why like it got a little bit delayed. And real apologies because you have been waiting for almost like 15-20 minutes extra. And thank you so much for all of your love. And Cerebellum Academy in the YouTube channel, you know very well that we are trying our best to educate the students every now and then. Hi, Dr. Abdullah K. It's not new dress. Basically, I didn't have time to change my dress. That is a problem because I just came from my OPD and just like that I'm starting the session. So and again, apologies for that for not changing the costume and just doing in the same costume. Very sorry for that. And hi guys, hi everyone. And everyone knows that yesterday was a blockbuster session by Dr. Zainab. Like, I mean, as usual, like her BTR sessions are generally blockbusters, and yesterday's session was also one of the like power packed and blockbuster sessions. And let us start medicine as such. So anyway, it's better that you do medicine after BTRs because yesterday I think Madam has covered the respiratory physiology part also. So I think you must be feeling a little bit easy to answer these kind of questions that I'm going to do it in the medicine part, and understand that medicine is slightly different from your basic sciences, but nevertheless the concepts are going to be the same. Yes, thank you so much for all of your love. So let us go on to the session. So what we are going to discuss basically, so we are going to have around 8 sessions, as I told you already, of all 8 major systems. Okay, PDF definitely will be provided, don't worry about that. So we're going to have all 8 major systems, okay, and each and every system will be discussing around 20 plus questions, okay? 20 plus questions. And so totally, when we have completed this medicine Saturdays, you will be uh, like having around 150 plus high yielding questions with associated discussion. And I can guarantee you one thing, that if you go through this 150 questions and their related topics, definitely you will be able to crack at least 90% plus medicine questions. So that's my sincere hope. And I have tried to include almost all of the most high yielding topics. So basically, it's not just the questions and the discussion that I'm going to make, it's going to be important for you. It's also going to be the topic as such. That's very important. So concentrate on those topics. So Deepu Singh is asking about if it's for FMG or post graduation. It is for both. So for both FMG as well as for NEET PG only, I'm doing this session. So yes, definitely, I'll try to do more sessions for FMG also. Okay, so don't worry about that. And I think if you look at what we are discussing in the Cerebellum Academic group, you will be coming to know that like we are trying so hard to do a lot of things for the students. In fact, like every time we discuss in the group, like it's almost always going to be about the students and only about the students. And today also they have been discussing like how much sessions that we can do for the FMG students before the exam on 20th itself. So that is what the discussion that is going on. We try to do as many sessions as possible for FMG also. How long the session is going to be? Session is going to be around like one and a half or maybe even 2 hours, depending on how fast you go and how slow we are going, and also depends on how you're going to answer in this session. So let us move on to the first question. I've given a brief introduction of what we're going to do. So first question, in pulmonary medicine and critical care, you have a 65-year-old man who's being evaluated for shortness of breath on exertion and dry cough that has worsened over the period of last 6 months. he has a history of coronary artery disease, atrial fibrillation, and he has a history of bypass surgery, that is coronary artery bypass grafting. He has clubbing and his vitals are stable. So FEV1 is approximately 65%. You know very well anything less than 80% is likely to be low, and more than 80% is likely to be normal or increased. Okay, so FEV1 is low, and you can see the FVC, that is the forced vital capacity, it is also low. And look at the FEV1 by FVC ratio, it is 74%. We know the only exception to the rule of 80% is going to be the FEV1 by FVC. So for FEV1 by FVC alone is 70%, not 80%. For everything else apart from FEV1 by FVC, it is going to be 80%. And total lung capacity is 68%, definitely less than 80, it is reduced. And you can see the DLCO, that is diffusion lung capacity of carbon monoxide, which is reduced at 62%. Which test is most likely to determine the etiology? So you have 4 options: bronchoscopy with transbronchial lung biopsy, echocardiography, HRCT chest, and PET CT of the whole body. The real question is not whether your ability to answer this or not. I wanted to know what is the diagnosis. So what is the diagnosis? I think definitely yesterday in the BTR session, Dr. Zainab has discussed about the PFTs, and you need to tell what is the diagnosis. What do you think is the right diagnosis? You all must be able to answer pretty easily. Okay, so let us evaluate. So what's going on in this PFT? So very well know, as a part of a 3-step protocol, the first step that we see while evaluating the PFT is the FEV1 by FVC, which is also referred to as something called as Tiffany index. So we're going to look at the FEV1 by FVC. So whether it is less than 0.7 or more than 0.7. For this only, our rule is 70%. So if FEV1 by FVC is more than 0.7, then it goes towards either a normal patient or a restrictive lung disease patient, or it's going to be a patient with pulmonary vascular disease. Patient with pulmonary vascular disease. Okay, so these are the 3 possibilities. In case if FEV1 by FVC is less than 0.7, the Tiffany index is less than 70%, you know it is very much suggestive of a obstructive lung disease. We all know that. It is very much suggestive of obstructive lung disease. So what is happening to our patient? To our patient, the FEV1 by FVC ratio is 74%, which means it is more than 70%. So we are assuming that the patient is likely normal or having a restrictive lung disease or having a pulmonary vascular disease. So the next step is going to be looking at FVC, that is forced vital capacity. So if you look at forced vital capacity, again you can determine whether it is less than 0.7 or it's going to be more than, sorry, less than 0.8, that is 80%, or more than 0.8, that is more than 80%. So if it's less than 0.8, you are thinking about a restrictive lung disease. If it's more than 0.8, you are thinking about a normal individual or a patient with pulmonary vascular disease. Pulmonary vascular disease. So look at our patient FVC. FVC is 67%. Everyone can understand that FVC is decreased. It's less than 80%. So definitely we are actually dealing with something called as restrictive lung disease. So now the next step will be to look at the DLCO, that is diffusion lung capacity of carbon monoxide. So whether it is less than 80% or more than 80%, that's the cutoff. So if it's going to be less than 80%, we are talking about intrinsic restriction, which means the most classical example of this is ILD, that is interstitial lung disease. And if it's more than 80%, that is a normal DLCO, we are going to think about extrinsic restriction, which means the lung is not the problem. The apparatus around the lung is the problem, which means the thoracic wall is having some issue, or maybe pleura is having some issue. So this could be either a neuromuscular disorder like neuromuscular weakness, which could be amyotrophic lateral sclerosis, or some other motor neuron disease, or Guillain-Barré syndrome, or poliomyelitis, something like that. Or it could be a bone problem like kyphoscoliosis, okay, pectus excavatum, pectus carinatum, okay, something like that. Or it could be a pleural problem. So of course we are not going to do a PFT for a patient with pleural effusion or a pneumothorax, but we do for some patients with pleural disorders like pleural plaques in asbestosis. So for those kind of situations, you can think about extrinsic causes where the DLC will be normal. Look at our patient. Our patient is having a DLCO of less than 80%, which means DLCO is reduced. It's less than 80%. So our patient is going to fit into this particular area, which means our patient in question is suffering from interstitial lung disease, an intrinsic problem, an intrinsic RLD, that is ILD. Okay. So on the other hand, like if you have a patient who is having a normal or pulmonary vascular disease, okay, now the next step is to do DLCO as well. If the DLCO is more than 80%, you're going to call it as normal. If the DLCO is less than 80%, you probably think about a pulmonary vascular disease. You probably think about a pulmonary vascular disease like pulmonary hypertension, or probably you can even think about pulmonary embolism. But anyways, in acute pulmonary embolism, we are never going to do PFTs for the sake of diagnosis. So we are talking about chronic pulmonary vascular problems like pulmonary hypertension. Okay, or even very early ILD. Okay, early ILDs can also have this picture where there will be only reduction in the DLCO. So as the ILD progresses, your FVC starts reducing, but in very early stages of ILD, you can have a normal spirometry with reduced DLCO alone. Even that is possible, but in most cases, as far as exams are concerned, you're going to diagnose a pulmonary vascular disease only. On the other hand, if it's suggestive of obstructive lung disease, now next step is to look at post-bronchodilator FEV1 by FVC, post-bronchodilator FEV1 by FVC. If post-bronchodilator FEV1 by FVC is less than 0.7, you're going to make a diagnosis of COPD, that is chronic obstructive pulmonary disease, which means if the post-bronchodilator FEV1 by FVC doesn't increase to more than 0.7, that is where we are going to define the disease as chronic obstructive pulmonary disease. If the post-bronchodilator FEV1 by FVC is more than 0.7, more than 70%, then it is not COPD. That is what you have to say. It is not COPD. It is not COPD. Then how will you differentiate these disorders? So depending on whether the patient is having a low DLCO or not. So you can look at the DLCO again. If the DLCO is going to be less than 80%, then you can think about the possibility of emphysema, because one of the very few obstructive lung diseases with a low DLCO is emphysema. And if it's going to be more than 80%, you can think about other obstructive lung disorders. Like there are plenty of other obstructive lung diseases, like you can think about bronchial asthma or chronic bronchitis, or you can think about like even bronchiectasis, cystic fibrosis. There are plenty of other obstructive lung disorders, but the commonest other obstructive lung disorder that we encounter in practice are going to be bronchial asthma and chronic bronchitis. So in that, chronic bronchitis is always a clinical definition. So how will you define a chronic bronchitis? If the patient is having chronic productive cough. So what do you mean by chronic productive cough? If the patient is having cough for at least more than 3 months in a year for at least 2 consecutive years. The patient is having productive cough with sputum for at least 3 months in a year for at least 2 consecutive years, you can make a diagnosis of chronic bronchitis. And bronchial asthma diagnosis is itself is a separate entity. I'm not going to discuss in this short session. So this is how you're going to evaluate a pulmonary function testing. So now you can understand, isn't it, how to evaluate a pulmonary function testing. And we know our patient right now is going to fit under a intrinsic restriction. So which means our patient is going to fit under ILD. So if it's an ILD, what is the ILD that the patient is having? You can suspect some ILD, isn't it? 65-year-old man, okay? Patient is having like clubbing, okay? Patient is having shortness of breath and dry cough for the last 6 months, which means it's having a chronic course. So patient is having a chronic course, elderly patient, okay, coming with ILD. So what do you think about? So you're going to think about a possible disease called as idiopathic pulmonary fibrosis, okay? So we cannot say it is idiopathic pulmonary fibrosis unless and until we do serological tests for ruling out other connective tissue disorders like rheumatoid arthritis or probably other problems, because rheumatoid arthritis also can produce a usual interstitial pneumonia-like pattern in the biopsy, and in the CT also they can produce IPF-like pattern. So that's why you need to do serologies to rule out like connective tissue disorders. And once you have ruled out that, in the HRCT itself, you will be able to make a diagnosis of IPF. And you all know the gold standard imaging technique for diagnosis of any ILD. If they ask you imaging in ILD, it is always HRCT. I'll repeat, imaging in ILD is always HRCT, as simple as that. That's all. Okay, so I need two things to say it is IPF. One, definitely I need a HRCT. Second, I need to do serologies to rule out connective tissue problems like rheumatoid arthritis. Okay, the two things that are required. The right answer for this question is going to be HRCT of the chest. Okay, I think this question doesn't need any more discussion. Let us move on to the second question. So look at this patient. So physician look at a patient's chest x-ray and made a diagnosis. Here is your chest x-ray. You can look at this. His room air saturation is 88% and PaO2 is 54 millimeters of mercury. Which of the following will improve survival? That's what I'm asking. First of all, you need to make a diagnosis. Okay, first of all, you need to make a diagnosis. What is the diagnosis here? So look at the chest x-ray and make a diagnosis. So what is the diagnosis? What the patient is having? You can easily make a diagnosis that this patient is suffering from COPD, that is chronic obstructive pulmonary disease. The patient is suffering from COPD. Why COPD? Because this patient is having, okay, flattening of the diaphragm, and this patient is having hyperinflated lungs. So this patient is having hyperinflated lungs, and this patient is having flattening of the diaphragm. And many people can notice also that the heart is more tubular in orientation. So you're also encountering a tubular heart. Tubular heart. So straightforward, the diagnosis is very, very likely to be a emphysema, because in emphysema only you are going to see hyperinflation predominantly. Very likely it's going to be an emphysema. So I mean, leave the emphysema part. So here the most likely diagnosis is COPD. So what is going to improve survival? So remember, there are only two known things in COPD that can improve survival. There are only two things that can improve survival. So what are the two things? One is going to be smoking cessation. Number one, smoking cessation, okay, which can improve survival. Number two is going to be long-term oxygen therapy. Long-term oxygen therapy, LTOT. These are the only two things that can improve survival. Remember, smoking cessation is mostly passive. I want to stop smoking. That is not a treatment. But if they ask you the therapy, the treatment that's going to improve survival, it is going to be LTOT. It is the only known treatment that's going to improve survival in patients with COPD. If they ask you two important things that can improve survival, then you can answer smoking cessation and LTOT. So you know the drugs. Many times people are going to ask about the drugs that are going to help in smoking cessation. So what are the drugs that help in smoking cessation? Number one, we have something called nicotine replacement therapy. So nicotine is available in the form of patches. Nicotine is available in the form of lozenges. We use called nicogums. It is available in the form of like sprays also. So we are going to use something called nicotine replacement therapy. That's the most common therapy that we use, but it's not the most effective. So you have a drug called as varenicline. So that's a very, very effective drug. In fact, one of the most effective drugs for smoking cessation. Next is bupropion. Okay, third one is bupropion. So simultaneously, you can also remember what are going to be the most important side effects or contraindications of each and every therapy. So nicotine replacement therapy, the most important side effect is going to be insomnia and vivid dreams. They can cause variety of gastrointestinal problems also, but insomnia and vivid dreams are going to be extremely important when it comes to nicotine replacement therapy. When you talk about varenicline, so you have to know that varenicline has some good things also, but you have to be careful in patients with depression because it can increase suicidal ideation. So in patients with depression and with suicidal ideation, you need to be careful with varenicline because it can increase suicidal thoughts. And bupropion will reduce the seizure threshold. which means bupropion can provoke seizures. That's another very, very important point. So 3 drugs, 3 important points. Nicotine replacement therapy, insomnia, vivid dreams. Varenicline, suicidal ideation, you don't give it. Bupropion lowers the seizure threshold. The best thing about bupropion is it produces weight loss, because many people after stopping smoking, you all know, they're going to develop weight gain. Why? Because they tend to eat more. And in fact, smoking cessation all of a sudden is a risk factor for new onset diabetes also. Because they eat more and at the same time they'll be depressed, and at the same time it can cause significant weight gain also. That's why smoking cessation is a risk factor for new onset diabetes. So bupropion is a natural antidepressant, so it can take care of the depression part and it can reduce the weight also. So it can prevent the post-smoking cessation weight gain as well. Okay, so these are advantages of bupropion, but it can lower the seizure threshold and can provoke seizures. So be careful in patients who are already having seizures or history of epilepsy. So the right answer for this question is going to be supplemental oxygen. So now the question is like, what are the indications? We don't use supplemental oxygen for all patients just because it improves survival. You need to know the clear-cut indications for LTOT in patients with COPD and probably even in some other ILDs. The number one indication is PaO2 less than 59 millimeters of mercury. Okay, or patients having saturation of less than 88%. Okay, that's the number one indication. Or I can say less than 55 first, 55 millimeters of mercury, or saturation of less than 88%. Okay, second, PaO2 less than 59 millimeters of mercury, or having a saturation of less than 89%, but plus, if you are applying the second rule, patient should have additionally either polycythemia. Some of the problems of chronic hypoxemia should be there. Patient should have either polycythemia or pulmonary hypertension, or patient should have cor pulmonale, which is nothing but a right heart failure due to a lung problem. A chronic lung problem causing right heart failure is what we call it as cor pulmonale. So if you are applying the second rule, then any one of polycythemia, pulmonary hypertension or cor pulmonale should be there. So look at our patient. Our patient is having, look at our patient. Our patient is having a PaO2 of 54 millimeters of mercury, which means it is less than 55 definitely. Okay, and you can see that the room air saturation is 88%. It is somewhere around 88-89%. So our patient is definitely a candidate for supplemental oxygen. So in case if you are using supplemental oxygen for LTOT, so you have to use it at least for more than 15 hours per day. If the patient is going to use for even 24 hours per day, that's not my problem. It is even better. But minimum recommendation is 15 hours per day he should be on oxygen. So you can usually start at a dose of 1 to 2 liters per minute. That's enough. 1 to 2 liters per minute. A low dose oxygen is enough, but some oxygen the patient should get. And if there is a right indication, use it at least for 15 hours per day. And the more you use, the better benefit that the patient is going to derive out of it. So now you know what are the things that improve survival in patients with COPD. And apart from that, you know the drugs that can cause smoking cessation, that can aid smoking cessation. Plus at the same time, you know the indications for LTOT and how to use long-term oxygen therapy as well. So remember the indications properly. Okay, PaO2 less than 55 or SaO2 less than 88%, or PaO2 less than 59 or SaO2 less than 89% with any one of either polycythemia, pulmonary hypertension or cor pulmonale. Okay, in the second indication it is 59. Okay, if it's less than 59, then you should have additionally any one of this. Then only you can start with LTOT, long-term oxygen therapy. So this question is also done. Okay, coming to question number 3. So you have a 29-year-old man with cystic fibrosis comes to the emergency room with 1 week history of worsening productive cough. Temperature is 39 degrees Celsius. Pulse rate is 98 per minute. Respiratory rate is 21 per minute. BP is 129 upon 76 millimeters of mercury. BMI is 17.5. Definitely BMI is low in this patient. Examination, bilateral crackles are heard in the lower lung fields. Chest CT shows prominent bronchiectasis. He's having bronchiectasis. Which of the following antibiotics is the most appropriate next step in the patient's infection? You're going to give ampicillin or cefuroxime or piperazolone tazobactam or ceftriaxone and metronidazole. So what is the antibiotic choice that you're going to use? Somebody is asking what in minute or hour. 1 to 2 liters per minute. Okay, so not hour. So yes, we are talking about acute exacerbation of bronchiectasis. This patient with cystic fibrosis is having bronchiectasis. And you know very well what is the type of bronchiectasis. So let us discuss some parallel important points also along with the discussion of questions. So cystic fibrosis means patient usually will have bronchiectasis because of plugging of secretions. And what is the type of bronchiectasis that the patient is going to have? The patient with cystic fibrosis generally tend to have a central or a proximal bronchiectasis. So in fact, there are only two things that you need to know whenever you talk about a central or proximal bronchiectasis. One is cystic fibrosis, second is ABPA, that is allergic bronchopulmonary aspergillosis. These are the two things that's going to produce central or proximal bronchiectasis. Okay, fine. So now you know patient is having bronchiectasis and they are prone for exacerbations. The most common reason for exacerbation in any bronchiectasis is infection. But remember, in patients with routine bronchiectasis due to other causes, okay, the most common reason for infectious exacerbation is Haemophilus influenza. You need to know that. Haemophilus influenza in most of the cases, but the most important exception is going to be cystic fibrosis, because cystic fibrosis organisms are going to be very, very different. That you need to know for sure. So in cystic fibrosis, you know what are the organisms that are going to colonize. So in the early stages, maybe in the first decade, so when you talk about the first decade, maybe up to like 6 years of life, okay, 6 or 8 years of life, most of the times it will be MSSA and other community acquired organisms. When you talk about CA, it's community acquired organism. It could be Haemophilus influenza also, but more often it is going to be staph, and that will be an MSSA. MSSA means it is methicillin sensitive staph aureus, which means it is a sensitive organism. But if you look at the second decade and beyond that, second decade, slowly the incidence of resistant organisms keep increasing. So now there will be increased risk of MRSA, and you are going to get pseudomonal colonization. Pseudomonas infection risk is also going to increase. But beyond second decade, okay, like around 25 years, 26 years, the most common reason for infectious exacerbations and colonization will become pseudomonas. After second decade, it's going to become pseudomonas. And there is an extremely high risk of MRSA and other resistant organisms. MRSA, also other resistant organisms like BCC complex. What is BCC complex? That is Burkholderia cepaceae complex. Okay, that is Burkholderia cepaceae complex. And also there is another bug called as Stenotrophomonas maltophilia. CA organism means community acquired organisms. Okay, community acquired organisms generally will be sensitive to the routine drugs that you are going to use. Stenotrophomonas maltophilia. Okay, so increased risk of Burkholderia cepaceae complex and Stenotrophomonas maltophilia. Remember, I'll tell you another important high yielding point, that Burkholderia cepaceae complex is a relative contraindication right now for lung transplantation. You know, cystic fibrosis patients are going to most often die because of respiratory failure and complications of the lung. So in fact, Burkholderia cepaceae complex, once like you find out the colonization by BCC, it becomes a relative contraindication for lung transplant in the future, because the lung transplant outcomes in patients with cystic fibrosis is going to be poor if they are colonized with Burkholderia cepaceae complex. Okay, that's the problem. So what I'm trying to say is, this patient is a 29-year-old patient. So which is going to be the most common infection in a 29-year-old cystic fibrosis patient? Which will be the most common infection? You can look at this and you can say which is the most common infection. First decade, MSSA. Second decade also it's staph only, but MRSA risk is very high. Pseudomonas risk is going to increase in the second decade, but around the third decade, like around 24-25 years, your Pseudomonas takes over. So the most common reason is going to be Pseudomonas after the second decade. So this, after BCC, what is written? That is Stenotrophomonas maltophilia. I'll repeat, Stenotrophomonas maltophilia. So we know very well that this patient is likely to have a Pseudomonas colonization. and this patient is likely to have an infection-related exacerbation which is due to Pseudomonas. And what is the drug that I'm going to choose? I'm going to choose piperazine tazobactam. Yes, pip-tazo, that's the drug of choice in this patient. So why? Because what are the drugs that can work for Pseudomonas? Usually we give a traditional mnemonic. This is my mnemonic called as campfire. So we have a mnemonic for that called as campfire. That's a mnemonic for anti-pseudomonal drugs. C stands for carbapenems. Can anyone say what is the carbapenem that doesn't work against Pseudomonas? You have to answer. What is the carbapenem that doesn't work for Pseudomonas? Okay, I'll tell at the end, but right now it's your job to find out. So carbapenems. A stands for aminoglycosides. M stands for monobactams. So there is only one monobactam that is available. That's going to be astrionum. That's the only monobactam available in market. And P stands for polymyxin drugs or polypeptide drugs like polymyxin B and colistin. And F stands for fluoroquinolones. And what generation fluoroquinolones are going to be effective? Only second and third generation fluoroquinolones. When you talk about fluoroquinolone, only ciprofloxacin and levofloxacin are going to be effective for Pseudomonas. None of the other quinolones are going to be effective for Pseudomonas. And IR stands for third generation cephalosporins. Okay, IR stands for, you can remember like third generation cephalosporin. In fact, in that only one third gen cephalosporin that is effective for Pseudomonas is going to be ceftazidime. Okay, ceftazidime. And we have found out a novel drug also. Even a fourth generation cephalosporin. Fourth generation cephalosporin also is going to be effective for Pseudomonas. In fact, this is the drug that is tailor-made for Pseudomonas. That's going to be cefepime. That is cefepime. This is one of the best drugs that you can use right now for Pseudomonas. And finally, E stands for extended spectrum penicillins. Extended spectrum penicillins, or these are also called as anti-pseudomonal penicillins. And the best example of an anti-pseudomonal penicillin is going to be pip-tazo, piperazine tazobactam. Or in India, we don't use it. That is ticarcillin clavulanic acid. Remember, somebody is asking about tobaramycin. Tobaramycin will come under aminoglycosides. Okay. So in this chart, I think you can understand this chart. In this chart, whatever I have written in red color are not first line drugs for Pseudomonas. They are only second line drugs. You can use it as an add-on cover. But whatever I mentioned in black are first line drugs, which means carbapenems are first line drugs like meropenem, imipenem, and extended spectrum penicillins like pip-tazo are first line drugs, and ceftazidime and even cefepime are going to be first line drugs. Okay, any one of these drugs you can use as first line for treating pseudomonal infections or suspected pseudomonal infections. Aminoglycosides are only for add-on. Monobactams are also like alternative drugs only, not first line. Polypeptide drugs like colistin are also alternative drugs only. Fluoroquinolones like cipro, levofloxacin are also alternative drugs only. Okay, clear? So, or maybe you can use an add-on, but not as a primary cover. That's very important. I asked one question in the beginning. Many people have answered it correctly. What is the drug that doesn't work for Pseudomonas? Being a carbapenem, that is ertapenem. So, ertapenem is the only carbapenem that doesn't work against Pseudomonas. So, if you have a Pseudomonal suspicion, don't use ertapenem, use meropenem or imipenem. So, because we are having a Pseudomonas suspicion here, we are going to use pip-tazo here. So that's the first line drug. Okay. So now I think this question is also done and dusted. Let us move on to the fourth question. You have a 68-year-old man presenting with persistent productive cough with clear sputum for the last 3 months. He also reports feeling of shortness of breath when using the stairs. He is a retired coal miner. His vitals are stable and examination reveals reduced breath sounds in all lung fields. PFT revealed a FE1 by FEC ratio of 60% and a reduced DLCO. Which of the following is likely? So what are you going to see? Either bilateral infiltrates or apical cavity lesion or hyperinflation with diaphragmatic flattening or a mass lesion with mediastinal lymphadenopathy. Which of the following findings is likely in this patient? Which of the following findings is likely? Okay, so now first of all, what the patient is having. Okay, so the clues that we are having is the patient is a retired coal miner. Okay, number one. So it's a retired coal miner, point number one. Okay, second clue, they are giving the PFTs. So FE1 by FEC ratio, so I told you 3-step protocol. FE1 by FEC ratio, whether it is more than 0.7 or less than 0.7. So here the patient is having FE1 by FEC ratio of less than 70%. So it is very much suggestive of obstructive lung disease. So they're not given the clue whether it is a COPD or not, but let us assume it's a COPD. But what they have given is patient is having a reduced DLCO. So that's a big clue. So what is the obstructive lung disease with low DLCO? So now you know it's an obstructive lung disease for sure. FN by FEC is 60%. So everyone knows, right? So what is the obstructive lung disease with a low DLCO? So I told you in exam you need to know only one thing, which is an obstructive lung disease with a low DLCO. What is that? That is emphysema. Okay, that is emphysema. So this patient is very likely to have a COPD or an emphysema. But can emphysema occur in a retired coal miner? Answer is yes. In fact, the most important take-home point and take-home message in this question is the fact that pneumoconiosis, especially silicosis and coal workers pneumoconiosis, can increase the risk of COPD and especially emphysema. I'll repeat, that's a very important point. Okay, many people think like when they talk about pneumoconiosis, they only talk about ILD or probably lung cancer. Okay, something like that. But remember, anyone, okay, who is having a silicosis or coal workers pneumoconiosis is also at high risk of developing COPD and emphysema. That is why the right answer for this question is option C. You are going to expect a hyperinflation with diaphragmatic flattening because we are talking about emphysema. Diffuse bilateral infiltrates will be seen in ILD, which can also occur in a patient with pneumoconiosis. Apical cavitary lesion is very likely to be suggestive of a tuberculosis, which can also occur in a patient with silicosis because silicosis increases the risk of tuberculosis. And mass lesion with mediastinal lymphadenopathy is going to occur in a patient with lung cancer, bronchogenic cancer, which can also occur in a patient with pneumoconiosis. So that is why this is a very, very special question. The answer is C. So if you look at the picture entirely, you can understand that this patient is having a COPD, nothing more than that. So which is predominantly an emphysema. The right answer for this question is going to be option C. Okay. Now let us go to the question number 5. So remember, pneumoconiosis is a very, very important topic in your exams. And coming to question number 5, you have a 35-year-old woman presenting with fever and pain in knees and ankles. Her BMI is 21, okay, which is normal. Temperature is 37.8 degrees Celsius, which means the patient is a little febrile. Pulse rate is 95 per minute. BP is 125.83 normal. So respiratory rate 14, which means the vitals are stable. Saturation is also normal, 99% in room air. On examination, she has bilateral parotid swelling and she has lesion shown in the picture below. So what is the lesion? You are going to find out. I'm not going to tell. Laboratory studies are normal except for a slightly increased calcium level. What is the most appropriate treatment? So this patient is having parotid enlargement, arthritis, fever, and the skin lesion that is shown here. Okay, and this patient is having a elevated calcium level. So what is the diagnosis? First of all, you need to make the diagnosis. So all this constellation tells you that the patient is having sarcoidosis. Okay, sarcoidosis. So it's a very common question in exam. So what are the important pointers in sarcoidosis? Let us quickly review. So first, when you talk about clinical picture, 2 important syndromes you need to know. So what are the 2 important syndromes that you need to know? One is going to be the Lofgren syndrome. So one is the Lofgren syndrome. So what are the features of Lofgren syndrome? Patient is going to have arthritis, patient is going to have erythema nodosum, and patient is going to have bilateral hilar lymphadenopathy. Okay, first syndrome. Second syndrome is Hereford syndrome, or otherwise called as Hereford-Waldenstrom syndrome. So this is going to have a classic tetrad presentation. So patient will be having fever, patient will be having uveitis, which will be a granulomatous uveitis. You would have studied in your ophthalmology. Sarcoidosis is one of the important causes of granulomatous uveitis. And patient will be having parotid enlargement. Usually it will be bilateral and symmetrical and painless parotid enlargement most of the times. And patient will be having facial nerve palsy. Most often than not, it will be a bilateral facial nerve palsy. In fact, the most common cranial nerve affected by sarcoidosis is 7th cranial nerve. So most of the times patients will be having a bilateral 7th cranial nerve palsy. Most often. It can be unilateral also. So this is the typical Hereford syndrome. So in exams, at least you need to remember these 2 syndromes. Okay, and what about the investigations? So most of the patients tend to have elevated serum calcium, not most really, around 10 to 20% of patients, but this is a very important clue in exam. So sarcoid granulomas contain the 1-alpha hydroxylase enzyme, which results in more vitamin D production. That is the reason why calcium levels will be high. And most of the patients tend to have elevated angiotensin converting enzyme also. And if you do bronchoalveolar lavage, you will see elevated CD4. And if you compare with CD8, CD4, CD8 ratio will be more than 2.5. So these are all very important pointers in exam towards sarcoidosis. And if they ask you investigation of choice, it is E-bus guided biopsy. E-bus guided lymph node biopsy, because most of the patients will have lymphadenopathy and you have to target the right lymph node. That is why we have an investigation called E-bus, that is endobronchial ultrasound guided biopsy. So that's going to be the most important investigation to prove or even disprove the presence or absence of sarcoidosis, where you're going to see non-caseating granulomas. Okay. Non-caseating granulomas. And sarcoidosis is treated with immunosuppression, but the first line treatment of sarcoidosis is going to be corticosteroids. We don't start corticosteroids for all patients. Okay, we don't start corticosteroids for all patients, but this is going to be the first line treatment. So here our patient is having erythema nodosum. Okay, in the picture. So these are painful tender lesions. Okay, that usually occur in the shin. So erythematous painful tender lesions, and it is commonly due to paniculitis. Paniculitis means fat inflammation. Okay, so this is erythema nodosum. So this patient is having fever, arthritis, parotid enlargement, erythema nodosum, increased calcium. So what are you going to diagnose? So it's straightforward. Sarcoidosis, the right answer is corticosteroids. Okay, the first line treatment is corticosteroids, most appropriate treatment. Okay, so now sarcoidosis is done. Coming to question number 6. You have a 29-year-old pregnant female, presence after consumption of iron tablets. Now we are slowly entering toxicology, and also we are slowly considering the emergency medicine discussion, the critical care discussion. So significant number of radiopaque pills are visible by chest X-ray. Which of the following intervention should be recommended initially for this patient? Okay, so is activated charcoal or gastric lavage or induced emesis with ipecac syrup, or you're going to give whole bowel irrigation? So what is the right answer for this question? So this patient, remember, she's having iron poisoning, oral iron poisoning. Remember, oral iron is very, very dangerous because it can release that free iron which can participate in Fenton's reaction and can produce free radicals, and that can subsequently cause oxidative damage to many different organs in the body. So many people are commenting activated charcoal as the answer, but no, activated charcoal is wrong. So why it is wrong? Because activated charcoal is contraindicated in certain areas. Number 1, first absolute contraindication is in a patient with low GCS. Okay, when a patient is in altered sensorium, or if the patient is having coma, definitely I'm not going to use activated charcoal for sure, because the risk of aspiration is very high. Number 2, late presentations. So yes, what do you mean by late presentation? Okay, late presentation means after 1 to 2 hours. For most poisons, if they present after 1 to 2 hours of ingestion, activated charcoal is not going to be effective, because most of the poison would have already been absorbed, or it would have gone down the intestinal tract. So there's no point. Number 3, in certain toxins where activated charcoal will be ineffective. So in certain toxins, activated charcoal will be ineffective. So what are those toxins? You can understand that for metal poisoning. So heavy metals, it's ineffective. Heavy metals like iron, mercury, it's ineffective. Number 2, for alcohols, it's ineffective. Ethylene glycol, methanol, propylene glycol, it's ineffective. Third, corrosives like acid or alkali poisoning. For corrosive poisoning, it's ineffective as well. Number 4, petroleum products like petrol, diesel, kerosene poisoning, ineffective. Number 5, inorganic ions. So what are the example of inorganic ion poisoning? Lithium poisoning. It's ineffective. And to be honest, even for boric acid poisoning, it's ineffective, but I don't know how much it's important. But you need to know, for these situations, activated charcoal is not effective. You cannot use it. So our patient is having iron poisoning suspected. So how can you use activated charcoal? You can't, it's ineffective. Gastric lavage is one of the outdated techniques. We don't even use gastric lavage in the modern emergency rooms. Okay, it's a very old technique. If you don't have any other option, then probably gastric lavage is fine, but that too, it should be done within like 30 minutes or 45 minutes of intake of a poison, and it increases the risk of aspiration significantly. So it's a very, very outdated technique. And option C, induced MSH ipecac syrup, is also a very, very outdated technique. It's only given in the literature. We don't even follow all this right now. So only thing that is feasible in this case is whole bowel irrigation. So what you're going to do by whole bowel irrigation, you're going to use an agent called PEG, that is polyethylene glycol. So you will use PEG at a dose of 500 to 1500 ml per hour depending on the age. So 500 ml per hour for a child and 1.5 liters per hour for an adult. So you are going to ask the patient to drink PEG orally, or you can give the PEG via nasogastric tube also. So how long you will give PEG? You need to see a clear effluent via the rectum. Till that you keep giving PEG after PEG after PEG. So which means you're literally washing out the entire gastrointestinal tract. So whole bowel irrigation will be helpful in certain important poisons. We can remember by the mnemonic called as LIMS. L stands for lithium, I stands for iron, M stands for other metals. Okay, heavy metal poisoning. P stands for body packers. You know who are body packers? Everyone has seen both Hollywood, Collywood, Tollywood, or even Bollywood movies where you know who are all going to be the body packers. And S stands for SR preparations, sustained release preparations, which are going to have a slow release. For these group of individuals, okay, we are going to use whole bowel irrigation, or you can consider whole bowel irrigation. But remember, in iron poisoning, you should have pills in the X-ray. So if you don't have any pills in the abdominal X-ray, why you want to give whole bowel irrigation? Which means the pills are already absorbed or it's not there. So why you want to give whole bowel irrigation? If the pills are visible in the chest X-ray and the patient is having iron poisoning, then the best step is to use whole bowel irrigation, not activated charcoal or gastric lavage. Okay. So the right answer for this question is option D. Okay. Let us move to the next question. And now again another toxicology question, because I've given two questions to emphasize the importance of like toxicology questions in your exam. Generally, if one question is a sure shot, but if you're lucky, you might get even 2 to 3 questions in toxicology. So be very clear. So 7th question, a farmer tried to commit suicide and has ingested about 2 glasses of paraquat. They're clearly given it's a paraquat poisoning. What is the primary system affected in paraquat toxicity? So dermatologic, renal, neurologic, pulmonary. So what is the primary? SR preparation stands for sustained release preparations. Somebody is asking about SR. So paraquat poisoning, what is the primary system that is affected? So remember, paraquat is a very, very dangerous poison. So even 30 ml of paraquat, that is a handful of paraquat, is going to kill you. And it's a very dangerous poison because it's going to cause a kind of a slow death. You know, like if somebody wants to die a very painful and a very slow death, slow and getting suffocated, take paraquat. It's a very, very bad poison. Like, so what paraquat is going to do, it's going to generate free radicals and it's going to cause some reactive oxygen species also that can damage like every single organ system in the body, but the primary organ system that will be affected is actually the lungs. Okay, so you're going to result in pulmonary fibrosis, and slowly but steadily the lung function will decline, and by around like 2 weeks or 3 weeks mark, the patient will suffer from severe hypoxemia and he's going to die if he has taken a decent amount of paraquat. But if you have not taken a decent amount of paraquat, still many patients will have a severe long-standing sequelae in the form of severe pulmonary fibrosis, and that will also not allow you to live peacefully after that. So don't take paraquat. It's a very, very bad poison. Okay. And what about the treatment? We don't have treatments. Remember, paraquat can cause multi-organ dysfunction also. So it can cause multi-organ dysfunction also. It can cause cardiac problem, liver injury, and so on. But the primary like organ system that is affected is the lungs, and that's why the right answer for this question is option D. So in exam, what will be the clues? The clue, number 1 clue will be a farmer, okay, in exam. Okay. Second clue, they might give a term called herbicide. So remember, if they are given the term pesticide, okay, then you can think about OPCs. But the patient would have taken paraquat if they have used the term called as herbicide. So paraquat is a herbicide. And another clue in exam will be severe local reactions. Severe local reactions. So what do you mean by severe local reactions? Severe local reactions. So in fact, the only farmer-related poison to cause severe local reactions like oral ulcers, like mucosal ulcers is paraquat. So farmer consuming herbicide, severe local reactions, there could be only one poison. It is paraquat. And 30 ml plus paraquat, 100%. There is a risk of severe pulmonary fibrosis and death within 2 to 3 weeks. And there is no antidote for paraquat. So serum paraquat can be measured, but it's not available in many centers. It's only a like matter of like suspicion, and you have to prove that the patient has consumed paraquat. And treatment is nothing. We don't know. We don't know the antidote. High dose dexamethasone along with plasma exchange has been tried by some areas, but I don't know. It's not going to work. And what's going to be the important treatment then? So nothing. Even oxygen cannot be given. Even oxygen cannot be given in this patient. Oxygen is relatively contraindicated. At end stage, there is no other option. We have to give oxygen only. But in early stage, oxygen is contraindicated in these patients because that can result in more free radical generation and more problem. Okay, the right answer for this question is option D. So even though it can affect every single other system, but the primary system that is affected in paraquat poisoning is the lungs and pulmonary fibrosis and respiratory failure and death. That is the usual course of paraquat poisoning. I didn't talk about iron. So what is the lethal dose of iron? Anyone who's going to take more than 65 milligram per kilogram of elemental iron, not the iron sulfate, of elemental iron, it's a risk factor for death. And the usual reason for death in patients with iron poisoning is going to be cardiopulmonary failure. So cardiopulmonary failure, that's the usual reason for death in patients with iron poisoning. Second, patients can develop hepatotoxicity and liver failure and they can die. Number 3, patients can also develop gastric outlet obstruction. This is a long-term complication, chronic complication. The patient survives the acute assault. Some patients can develop gastric outlet obstruction as a sort of chronic complication because iron will generate free radicals even in the gut. If you are taking too much of iron tablets, that free radical related damage can cause pyloric stenosis in the antrum. So chronic complications. So if they ask you the antidote of choice for iron poisoning, answer will be IV deferoxamine. IV deferoxamine will be the antidote of choice as far as iron poisoning, acute iron poisoning is concerned. So that's done, over. And now moving on to question number 8. So you have a 58-year-old demolition worker. So now I clearly said it's a demolition worker. Presenting with a vague pain in the left chest with mild shortness of breath for 2 months duration. There is dullness on percussion on the left chest associated with reduced breath sound. Chest X-ray is shown. So chest X-ray is not there here, but let me say that, I don't know why it is not there, but let me show the chest X-ray. So the patient is having a kind of a scalloped margins like this on the right side. So which means there is a lesion that is present through and throughout the lung. Okay, throughout the lung. There is blunting of costophrenic margins and it is causing scalloped borders. It is causing scalloping and scalloped borders. So let us assume that is the finding in the chest X-ray. So the following is the likely diagnosis. Pleural effusion, pleural plaque, mesothelioma and diaphragmatic hernia. Okay, so what is the right answer? So I'll give you 10 seconds for you. Okay, the right answer for this question is going to be mesothelioma. It's a malignant mesothelioma. So what are the pointers? First of all, the patient is a demolition worker. So working in demolition industry is a risk factor because they are going to work with old buildings. Old buildings are going to have paints and pipelines that are made of asbestos. Okay. So the risk of asbestosis is there. Because there is a risk of asbestosis, you need to always think about a lot of possibilities like ILD, benign pleural plaques and even a mesothelioma. So remember, this patient is having dullness on percussion on left side of the chest. So it could be either pleural effusion or sometimes even a pleural plaque or even a mesothelioma, but not diaphragmatic hernia. If it's a diaphragmatic hernia, patient should have a tympanitic node because it's the bowel that's going to come into the chest wall. So I'm not going to anticipate that. So that's a dummy choice. That's a wrong answer. But I told you very clearly in the X-ray, you are seeing blunting of the costophrenic angles. Along with that, there is a lesion that is encasing the entire lung, and it is causing scalloping. Scalloping means it's causing as if something is eating the patient's lung, as if it is eating the patient's lung. So what is going to encase the lung and start eating the lung? It's not going to be pleural effusion. If it's pleural effusion, you will see a nice meniscus sign. So where in the lower portion you will have a relatively lower edge of the effusion, but as you move to the lateral side, you're going to see more like the pleural effusion will go upward, and it's going to cause a nice meniscus sign. So we're talking about a mesothelioma here. Okay, that's what is going to occur. So pleural plaques will not be like this. Pleural plaques will be like clover leaf here and there. It will not be like surrounding the lung, encasing the lung and start eating the lung with causing scalloped margin. So the right answer for this question is mesothelioma. So now let us look at some of the important occupational lung disorders. So let me put a table for that. It's a very simple table. So first I'm going to write silicosis over here. I'm going to write asbestosis, then coal workers pneumoconiosis, then finally we can write berylliosis. So these are the 4 important pneumoconiosis. Number 1, okay, which is the most common pneumoconiosis? Silicosis. Silicosis is the most common pneumoconiosis. So which is going to cause ILD? All of them can cause ILD. Okay, all of them can cause ILD, interstitial lung disease. Second, which is going to cause pleural involvement? Which is going to cause pleural involvement? So the only thing that causes pleural involvement is asbestosis. Asbestosis is the only thing that causes pleural involvement. None of the other pneumoconiosis tend to cause pleural involvement. In fact, pleural involvement is the most common finding in most of the asbestosis patients, where it's going to cause something called as benign pleural plaques. Okay, it's going to cause something called as benign pleural plaques. And remember, these are really benign plaques, and it's not going to cause increased risk of mesothelioma in the future. And one more thing I can say, that the pleural plaques are not going to get converted to mesothelioma. Remember, it is not recorded, Dr. Akhil Raj. It is not recorded. It is a live session only. And I'll reply to your queries later on. First, let us finish off the questions. Okay, so I'll reply to your queries. So benign pleural plaques. Okay, that's the most common finding in patients with asbestosis, and they are not precursor lesions for mesothelioma. Number 3, what about lymph node involvement? Lymph node involvement can occur in almost all the pneumoconiosis except asbestosis. Asbestosis usually does not cause lymph node involvement. And number 4, what about bronchogenic cancer, that is lung cancer? So what about lung cancer? Lung cancer also is common in almost all the pneumoconiosis. The only exception for that is coal workers pneumoconiosis. This alone usually does not increase the risk of lung cancer that much. And you need to understand that lung cancer risk is increased if the patient is a smoker. If the patient is smoking, then the lung cancer risk will increase significantly. And the type of lung cancer, bronchogenic cancer, that pneumoconiosis patients tend to get is adenocarcinoma. Okay, adenocarcinoma. The type of lung cancer that patients tend to develop with pneumoconiosis is going to be adenocarcinoma. And what is the latency period for developing lung cancer? The latency period for developing lung cancer is going to be approximately 15 to 20 years. So after exposure to asbestos, 15 to 20 years later, there is a risk of developing lung cancer. And what about number 5? Number 5, mesothelioma. Okay, mesothelioma. So mesothelioma, you know very well, it's going to occur only with asbestosis. None of the other pneumoconiosis is going to increase the risk of mesothelioma. It's very, very important. So we are talking about malignant mesothelioma, not a simple like benign mesothelioma, malignant mesothelioma. Only asbestos is going to increase the risk. An important point to know is there is no etiological association with smoking. Whether the patient is a smoker or not, it's not a problem. Okay, if he smokes or doesn't smoke, still the risk of mesothelioma is going to be the same. No etiological association with smoking. Second, latency period. Latency period is going to be 25 to 30 years, which means mesothelioma has a longer latency period compared to that of lung cancer itself. So 25 to 30 years later only they're going to develop mesothelioma, if at all they're going to develop. And finally, let us see some of the other important points. So what are the other important points? When it comes to silicosis, you know it is the most common pneumoconiosis or most common occupational lung disorder, and there is going to be increased risk of tuberculosis. In fact, the only pneumoconiosis that's going to increase the risk of tuberculosis is silicosis, and that's called as silicotuberculosis. And in exam, another clue will be something called eggshell calcification. Even though eggshell calcification can be seen in plenty of other disorders, but in exam, always tend to diagnose silicosis, eggshell calcification. And what about asbestosis? Asbestosis is famous for lower lobe involvement. Okay, lower lobe involvement. So remember, all the pneumoconiosis, okay, is going to typically involve upper lobe, upper lobe, upper lobe. The only exception for that rule is asbestosis, which is going to involve lower lobe. So lower lobe involvement is the key for asbestosis, point number 1. Second point, in exam, they might give another pointer called as ferruginous bodies. These are asbestos particles that are engulfed by macrophages and coated with iron. That's what are ferruginous bodies. So lower lobe involvement, ferruginous bodies. And benign chlor leaf shape pleural plaques, all these are basically evidence of asbestosis. Number 3, coal workers pneumoconiosis. It's divided into 3 types. Okay, number 1, that's called as anthracosis. Anthracosis is a incidental finding. Anthracosis tends to be found incidentally, which means patient will be completely asymptomatic, and even imaging will be normal. Even chest X-ray will be normal. So in autopsy, after the patient has died or during some surgery, you can see some lymph node will be black in color, and the macrophage in the lymph node will be black in color. Okay, that is what we call dust cells, and that's called anthracosis. Asymptomatic, normal imaging. And second, simple coal workers pneumoconiosis. Simple coal workers pneumoconiosis, where patients will be having some nodules in the chest X-ray. So here the patient will be asymptomatic, but chest X-ray will show some nodules. Some small nodules will be there. And third one is progressive massive fibrosis. Okay, progressive massive fibrosis, PMF. So where the patient will be symptomatic because it's a massive fibrosis, and chest X-ray will show ILD, fibrosis with many nodules. Okay, large nodules. Large nodules will be there. Okay, large nodules will be there. Okay, so these are the important pointers. And what are the important things about berylliosis? Berylliosis, the most important differential diagnosis for berylliosis is going to be sarcoidosis. Sarcoid is the most important differential diagnosis because berylliosis also tend to produce non-caseating granulomas. So sometimes it's literally impossible to differentiate berylliosis from sarcoidosis. So they can also produce non-caseating granulomas. So how will you differentiate berylliosis and sarcoidosis? That's why you need to know the diagnostic triad, how you are going to make a diagnosis. So diagnosis will be done based on the demonstration of non-caseating granulomas in biopsy. Okay, number 1. Second, you need to prove the history of beryllium exposure. So which group of patients are known to get exposed to beryllium? Patients who are in the construction industry, patients who are in the aerospace industry or nuclear industry, nuclear and aerospace industry, high risk of beryllium exposure. Third, there is a test called as BLIP. So what is BLIP? This is called as beryllium lymphocyte proliferation test. This should be positive. I repeat, that's called beryllium lymphocyte proliferation test. That should be positive. Okay, so this is how you diagnose a berylliosis. It's a difficult diagnosis to make, but still there's no other way to make a diagnosis of berylliosis. And many people are commenting on Kaplan syndrome. Any pneumoconiosis can produce Kaplan syndrome. Any pneumoconiosis can produce Kaplan syndrome, technically. Kaplan syndrome is nothing but combination of rheumatoid arthritis and upper lobe nodules due to pneumoconiosis. Usually it will be due to silicosis. The most common pneumoconiosis that produces Kaplan syndrome is silicosis. Silicosis is the most common pneumoconiosis that produces Kaplan syndrome. So remember, it is not like patient will develop rheumatoid arthritis and develop pneumoconiosis. It's the other way around. Patient will develop pneumoconiosis first. For example, patient will develop silicosis first in their younger age during some occupational hazard or occupational exposure, and that increases the risk of rheumatoid arthritis in the future because pneumoconiosis is a risk factor for rheumatoid arthritis. So initially pneumoconiosis in their younger age, then that increases the risk of rheumatoid arthritis. And once they develop have upper lobe nodules along with rheumatoid arthritis, which they develop later in the future, that is what we call as Kaplan syndrome. The most common reason is silicosis. Okay, so now I think like the entire pneumoconiosis section is done in a single table. So that's a very high yielding table which I have discussed. So now let us move on to question number 9. Okay. Benign mesothelioma can have association with all? No. Benign mesothelioma is sporadic. It doesn't even have association with any of the pneumoconiosis. So coming to respirology, question number 9. Okay. 40-year-old man is seen in a routine health checkup. He has no past medical history and currently asymptomatic. His physical examination is normal. His blood workup appears normal as well, which means everything is normal. It's a routine health checkup. So his chest X-ray is abnormal and shown. Which of the following is the likely diagnosis? Which of the following is the likely diagnosis? You can look at what is going on here. So anyone wants to diagnose? So what's going on in the X-ray? So first look at the X-ray and look at the CT scan. In the X-ray as well as in the CT scan, you're able to see something called as a solitary pulmonary nodule. So remember, to define a solitary pulmonary nodule, the lesion should be less than 3 cm. First of all, if it's more than 3 cm, it becomes a mass. I'll repeat, more than 3 cm becomes a mass. Less than 3 cm is solitary pulmonary nodule. So this is a solitary pulmonary nodule and the patient is asymptomatic. And it shows calcifications. And what is the type of calcification? It is popcorn type calcification. That's correct. So the right answer for this is pulmonary hamartoma, otherwise called as pulmonary chondroma. So calcified TB granuloma will not show popcorn calcification. It can show circumferential calcification, or that is circular calcification, or it can show like dense, full, entire lesion can be calcified. So that's how TB granuloma presents. Bronchogenic carcinoma will have a spiculated margin. So that's different. Pulmonary metastasis also will be presenting as a soft tissue mass, not with calcifications usually. So the right answer is hamartoma of the lung. So coming to respirology, question number 10. So pheno in bronchial asthma related to. So this is a question I anticipate in the next few exams because this is being increasingly used nowadays by most of us in practice. Pheno stands for fractional exhalation of nitric oxide. So in bronchial asthma, why you are using it? Typically we use in bronchial asthma. That is because to find out the presence or absence of eosinophilic inflammation. Okay. So for finding out whether the patient is having bronchoconstriction or not, you are going to use pulmonary function test. So I'm going to use FE1 by FEC ratio for this. Mucus hypersecretion is basically a clinical diagnosis. The patient will have chronic cough if it's going to be a mucus hypersecretion. Airway hyperreactivity can be diagnosed by a test called as methacholine challenge test. Test is called as methacholine challenge test. So that is for airway hyperreactivity, but for predicting eosinophilic inflammation, we use fractional exhalation of nitric oxide as a marker. So different guidelines say different cutoffs. We calculate in parts per million. So it depends on the instrument that you use. But why we wanted to know whether the patient is having eosinophilic inflammation or not, that is because we can try biologicals. Okay. So if the patient is having eosinophilic inflammation, we can try biological drugs. So what are the biological drugs that are approved for asthma? And a very important question for exam, because now the question paradigm is actually shifting towards biologicals. So first, we have to know that asthma is a Th2 inflammation. So there are 3 signature cytokines of Th2 pathway. One is interleukin 4 and second is interleukin 5 and next is interleukin 13. So interleukin 4 is important for class switching to IgE. Interleukin 5 is important for activating eosinophils, okay, and eosinophilic inflammation. And interleukin 13 is important for mucus hypersecretion. For mucus production, interleukin 13 is important. So what are the important drugs? So a monoclonal antibody that is used to block IgE is called as omalizumab. Everyone knows that. And monoclonal antibody that is used to block IL-4 is dupilumab. And monoclonal antibody that blocks IL-5 and its receptor is going to be mepolizumab and reslizumab. And a monoclonal antibody that's used to block IL-13 is called as benralizumab. Sorry, this is not benrali, this is lebrikizumab. It is not available in market. Remember, benralizumab is also a anti-IL-5 only, but it blocks the receptor. That's why it's called benrali. Okay, benralizumab, it blocks the receptor. So this is also going to block the IL-5 only. So IL-13 blocker is actually lebrikizumab. It is the only thing that's not available in market right now in practice, but otherwise most of the other drugs are available in practice. Many are available in India also. So anti-Ig omalizumab, anti-IL-4 dupilumab, IL-5 mepolizumab, reslizumab, benralizumab. Benralizumab is the receptor blocker, and IL-13 and blocker will be lebrikizumab. Any one of this can be used. So for that I need to know first of all it's a eosinophilic inflammation or not. That is the reason why I am using FeNO, that is fractional acceleration of nitric oxide, even though it is not very well validated right now, but still very important for your understanding. Okay, now coming to question number 11. You have 40-year-old woman without any past medical history, presents for evaluation of 3 months of progressive shortness of breath on exertion. She undergoes pulmonary function test with revealed DLCO of 45%, which means DLCO is reduced. Her spirometry and total lung capacity are within normal limits, which means her FEV1 by FVC is normal, her FVC is normal, and her total lung capacity is also normal. So all are normal. Which of the following diseases could the PFT findings not support, which means it's a negative question. So we can conclude it as all of the following except. So which means everything is normal, only DLCO is reduced. So all of the following are possible except. What is the right answer? So remember, early ILD, yes, you can have an isolated DLCO reduction. It tends to produce a low DLCO without altering the spirometric values. I told you just a while ago in the beginning of the session. And what about pulmonary embolism? Pulmonary embolism is a pulmonary vascular problem. So FE1 by FVC, FVC as well as TLC will be normal. There will be an isolated DLCO reduction. And pulmonary hypertension also a similar kind of disease where spirometry will be normal but DLCO may be reduced. But right answer for this is motor neuron disease. It's an extrinsic RLD. I told you already. The FE1 by FVC will, in motor neuron disease, what will be the picture? FE1 by FVC will be normal, okay, which means it will be more than 70%, and FVC will be reduced, which means it will be less than 80%, and DLCO will be normal because it's a extrinsic problem, okay, it's a extraparenchymal disease. So the right answer for this question is motor neuron disease. Method 1, PE be acute presentation, will it be a 3 months history? PE can present acutely, or we have chronic thromboembolic pulmonary embolisms also. So, but most classically, PE is going to present in an acute fashion. So, right answer for this question is option C. So, coming to question number 12, you have a 24-year-old lady presenting with fever and running nose for the last 3 days. On examination, she has a temperature of 38 degrees Celsius and has bilateral maxillary sinus tenderness. What is the next step? Dr. Sean Murphy is telling all the questions are easy. So why can't Dr. Sean Murphy answer it first, this question? So what is the right answer for this question? So what is the next step? So annotated PDF will be definitely provided, Dr. Shahista. Sorry if I pronounced wrongly, doctor. So definitely I'll provide the annotated PDF in the Telegram group. No problem. So what is the next step here? So 24-year-old presented with fever and running nose for the last 3 days. Okay, on examination she has a temperature of 38 degrees Celsius and bilateral maxillary sinus tenderness is present. What is the next step? So Dr. Sean Murphy is repeatedly telling that all are easy questions, but unfortunately answer it incorrectly. The right answer is not B. The right answer is only supportive care, because sometimes patients will be presenting. No, it's supportive care only. Why? So, I mean, in exam, sometimes they can ask about the upper respiratory tract infections also. This patient is having a acute rhinosinusitis. Okay, this patient is having an acute rhinosinusitis. Telegram link, I'll tell you like at the end of the session. So, patients are going to have acute rhinosinusitis here, and most of the times, acute rhinosinusitis is going to be because of viral infections. Okay, it's viral infections only most of the times. So all it needs is supportive care. No need to do anything. No need to give antibiotics. Okay, so no need to give azithromycin. And in fact, azithromycin has become an over-abused drug in practice because everyone have abused azithromycin like anything. Okay, during the COVID era and even in the post-COVID era. So we're seeing so much of azithromycin resistance. It's not going to be the first choice drug at all. And then CT scan of the maxillary sinus is also not a very good option. CT scan of the maxillary sinus, because CT scan will be done only in complicated cases, in acute cases. So what's going to bother you really? Okay, so just treat with supportive care like steam inhalation and just give some paracetamol and supportive care. Okay, and that's more than enough because it's an acute viral rhinosinusitis. Okay, so when you will start with antibiotics, augmentin, that is amoxicillin clavulanic acid, is a decent choice. I'm not saying it's not a wrong choice, it's a decent choice, but only in patients with complicated rhinosinusitis or complicated sinusitis where you're thinking about bacterial infection. When you think about bacterial infection, okay, when there is persistent symptoms, like even more than 10 days the patient is having persistent symptoms, or probably if the patient is having elevated total leukocyte count, or if the patient is having, or we can say elevated total WBC count, or the patient is having very high CRP, like more than 40 generally, is a sign of bacterial infection. Or if the patient is having some other signs of bacterial infection like persisting fever, patient is very toxic, and if the CB peripheral smear shows a left shift towards the left shift in the neutrophils. So in those situations and all, you can start with antibiotics. Otherwise, there is no need for antibiotics. Most of the acute viral or acute rhinosinusitis will be due to viral cause, and that can be treated supportively. So right answer for this question is supportive care only. So nothing else is required. Coming to question number 13. In which of the following situations would NIV be considered to be contraindicated? So indirectly, I'm asking what is the contraindication for NIV? That's all. So Dr. Pavitra is telling fever alone is not an indication for antibiotics. Even in viral rhinosinusitis, you will have fever. But persistent fever, toxic looking patient, okay, elevated WBC count, CRP very high, okay, or persistent symptoms beyond 10 days. Okay, so these are the usual reasons why you start with antibiotics. Otherwise, acute 2 or 3 days, symptomatic, just treat symptomatic, nothing else is required. Okay, which of the following situations NIV is considered to be contraindicated? So is it acute exacerbation of COPD or ARDS or acute myocardial infarction or post-extubation? So the right answer for this question is going to be AMI, that is acute myocardial infarction. Okay, that's the right answer for this question. So why acute myocardial infarction? Pretty simple and straightforward. In patients who are having cardiac issues, generally we don't use NIV. So what are the contraindications? What are the contraindications for NIV? The number one contraindication that you need to know for NIV is low GCS. So low GCS, because whenever the patient's GCS is low, patient is in altered mental state and patient probably may be in coma. And that's going to significantly increase the risk of aspiration, because when you give an NIV from outside, you're going to increase the pressures not only in the respiratory tract but also in the gastrointestinal tract, and the intragastric pressure is going to increase. That will be gastric insufflation, and that's going to cause increased risk of like vomiting and aspiration and subsequent Mendelssohn syndrome. You don't use it. Okay. Number 2, second important contraindication. Patients who are having hemodynamic instability. Very, very important. Unstable vitals. Don't use it. You intubate straight away. Third, patient who's vomiting continuously, severe vomiting or having UGI bleed. That's a natural contraindication. If the patient is vomiting continuously, if the patient is having UGI bleed, how can you use NIV? Apart from that, ill-fitting masks. If the size is not adequate, okay, ill-fitting mask, size is not adequate, it's very small, too big, so you will not be able to maintain the positive pressure. So that's a contraindication. Patient who's having a facial injury or malformation. Facial injury or malformation, very important contraindication. There's severe facial injury. Okay, how can you use? You can't use it. Number 6, acute myocardial infarction, or in exam they can use the term ACS, that is acute coronary syndrome. Here also it's contraindicated, you can't use. Or any other situation like cardiac tamponade or any like severe cardiovascular issues, you don't use NIV generally. But the most important example is acute MI and ACS. If it causes pulmonary edema, I'm not going to use it. So in acute exacerbation of COPD, can you use or not? Definitely yes, I can use. There's no problem. In fact, what is the indication, okay, of acute exacerbation of COPD? What are the indications of acute exacerbation of COPD? In acute exacerbation, number 1, Praveen sir, I don't know. I think it is like a hit and run. I think, I don't know, sir is trying to tell my handwriting is similar to mine. So he's trying to like praise me, or is difficult to understand. He's trying not to praise me. I don't know what sir is trying to say. But anyway, I'm feeling happy that sir is telling my handwriting is similar to his. I'm very happy for that. Okay. So number one indication is going to be pH less than 7.35. Okay. Or pH less than 7.35, or alternatively PaCO2 more than 45. Okay. This is the number one indication. Okay, in acute eczema COPD, I'll repeat, this is a very important indication. pH less than 7.35 or PaCO2 more than 45, or both. Okay, so that's the number one indication. If pH is less than 7.25, most guidelines suggest that you don't use NIV, rather you intubate. Better. Endotracheal intubation. ETT stands for endotracheal intubation. That's better. Because it's a very severe acidosis, so there is a high risk of NIV failure. That's why if it's less than 7.25, don't. If it's 7.25 to 7.35, plus or minus PaCO2 more than 45 millimeters of mercury, yes, it's a very important indication for NIV. Because NIV, especially BPAP, that is bilevel positive airway pressure, in the setting of acute exacerbation of COPD, is very, very beneficial in reducing the length of stay in the hospital and in reducing the intubation rates. The amount of endotracheal intubation rates and the length of stay in the hospital is also going to reduce if you use BiPAP for correct patients during acute exacerbation of COPD. Second, ARDS. Okay, ARDS, whether NIV can be used or not, yes, you can use it, but there is a high risk of NIV failure. Remember, ARDS is not a contraindication for NIV. Be very clear, ARDS is not a contraindication for NIV, but we generally don't use non-invasive ventilation because the risk of NIV failure is very high. That's why ARDS is not the right answer in this question, because it's not contraindicated, but even though we don't use it often. Post-extubation, very, very common. Okay, after extubation, to prevent reintubation rates, to reduce the reintubation rates, to reduce the rates of reintubation, we use NIV. There's no doubt about that. Okay, even in some post-op cases also, you can use NIV to reduce the rates of reintubation. Okay, so reduce the rates of reintubation, definitely we can use NIV. So right answer for this question is going to be option C, that is acute myocardial infarction. So coming to question number 14. So all of the following treatments have supporting evidence for efficacy in early ARDS except. So early use of paralytic agents, fluid restriction, glucocorticoids, prone positioning. So which of the following does not have evidence of efficacy in ARDS? I'll repeat, which of the following does not have efficacy in ARDS? What is the right answer? Either early use of paralytic agents, or fluid restriction, or glucocorticoids, or prone positioning. The right answer for this question is glucocorticoids. Okay, so glucocorticoids don't have evidence to support their efficacy in patients with ARDS. That's very important. So many guys may be thinking like in COVID we used dexamethasone left and right. So remember, that's for COVID, not for any other cause of ARDS. So severe COVID pneumonia, yes, dexamethasone has been proven to be like effective and it improves survival. But in ARDS, apart from COVID, no. So what are the things that are going to be beneficial in patients with ARDS? Number one, low tidal volume ventilation. So what is the routine tidal volume that you use in your ICUs? 8 to 10 ml per kilogram. So 8 to 10 ml per kilogram is the routine tidal volume that you're going to use in ICUs. But in patients with ARDS, okay, this is normal. In patients with ARDS, you should make the tidal volume 4 to 6 ml per kilogram. 4 to 6 ml per kilogram. That is called as low tidal volume ventilation. And in fact, this is the only technique that has been known to improve survival in patients with ARDS like anything. We have so much of strong and concrete evidence to say that low tidal volume ventilation improves survival in patients with ARDS. Very, very important. In exam, you see low tidal volume ventilation, and that's going to be the answer for ARDS. Okay. So when I talk about ventilator settings. Second, high PEEP. Okay, PEEP is important, but you have to titrate. You have to titrate PEEP accordingly. So it's not like high PEEP ventilation. PEEP is very important. So, but titration of PEEP is more important than just setting high PEEP or not. But starting point will be 5 centimeters of water. Starting point will be 5 centimeters of water. Okay. So that's the starting point for PEEP. But you have to titrate based on what is the other ventilatory settings. Third, fluid restriction, or more importantly, we can say conservative fluid management. Conservative fluid management. So why? Because they have proved that fluid overload in patients with ARDS is going to increase the risk of lung injury further by causing more exudation. So that's why you need to manage the fluids conservatively, even though this technique has not shown to improve survival, but this is effective. At least it's not increasing mortality. So fluid restriction or conservative fluid management is not going to really increase survival, but at least that it doesn't increase mortality. But fluid overload definitely increases mortality. Number 4, early use of paralytic agents. Again, this is something that has not been shown to concretely improve survival, but it will reduce the ventilator patient dysynchrony. So I think in anesthesia you would have studied something called curar cleft, isn't it? So in reality, that is nothing but poor use of paralytic agents. If your neuromuscular blocker dose is inadequate, the ventilator will be doing something, patient will be doing something else. Patient might be just breathing in. Patient might be breathing in at that point where the ventilatory phase is expiration. So if there is ventilator patient dysynchrony, that's going to increase the risk of lung injury further. So that's the reason why we need to use paralytic agents. So you should completely knock out the patient. There should not be any inspiratory efforts, at least in the early stages, to prevent this ventilator patient dysynchrony. So whenever you see the curar notch in EtCO2, always think that the patient is under paralyzed. So you need to increase the dose of paralytic agents, especially ARDS. That's very, very important. Number 5, we all know that prone positioning is very, very good. Maybe before 2016, we did not have good evidence for that. But right now, we have excellent evidence for prone positioning. If at all you want to prone the patient, it should be at least more than 16 hours per day. But it should be a trained team, because proning is not that easy. Okay, pulmonary edema decreased by fluid restriction. Yes, it reduces by fluid restriction, because ARDS is also a type of pulmonary edema, but it's a non-cardiogenic pulmonary edema. That's all. That's why fluid restriction is very, very important. So prone positioning, more than 16 hours per day, has been shown to be definitely beneficial. So early use of paralytic agents, beneficial. Fluid restriction, beneficial. Prone positioning also beneficial, but steroids, no. So if they specifically ask COVID, then answer is yes. But in other ARDS, no. And another thing that they may be asking in ARDS is the definition. So currently we use something called as New Berlin 2016 definition for ARDS. So accordingly, first you need to prove the acute onset of the disease, which means within 7 days of insult to lung injury. So number 2, you should prove that the patient is having bilateral infiltrates in imaging. It could be chest X-ray or probably CT scan, bilateral infiltrates. Third, it should be non-cardiogenic pulmonary edema. It should not be cardiogenic. So previously in the old definition, they have used PCWP to say it is non-cardiogenic. It should be normal or low. But currently, there is no need to use PCWP. Your pulmonary edema should not be explained by the patient's heart failure. That is what the guidelines are saying. Even if the heart failure is present, if the pulmonary edema is not explained by the presence of heart failure, that is non-cardiogenic pulmonary edema only. So non-cardiogenic pulmonary edema. Okay. Then finally, number 4, you have to prove the presence of severe hypoxemia. Remember, ARDS is a condition where the patient is going to have severe, in fact, very severe hypoxemia. Without intubating the patient, many times you can't even manage these cases. The patient might get 100% FiO2 through the NRBM mask, but saturation will be dipping at 60-70%. So severe hypoxemia. So how will you define severe hypoxemia? So the patients will have a PaO2 FiO2 ratio. Definitely PDF will be provided, Dr. Farhan, don't worry about that. So PaO2 FiO2 ratio should be less than 300 with a PEEP of at least 5 centimeters of water. With a PEEP of at least 5 centimeters of water. So that's a very important point. It's not just a PF ratio of less than 300. With a PEEP of 5 centimeters of water, if the PF ratio is less than 300, that proves the severe hypoxemia. If this criteria is matching, then you can make a diagnosis of ARDS. You can make a diagnosis of ARDS. 100%, no doubt. Okay. So based on the PF ratio, you can tell the severity of ARDS also. If it's less than 300, it is mild ARDS only. If it is less than 200, it is moderate ARDS. And if it's less than 100, you can say it's a severe ARDS. Okay, the most common cause of ARDS right now is sepsis, that is endotoxic shock, followed by second most common cause is pneumonia, direct lung injury. Okay, number one, sepsis, endotoxic shock, and that's gram-negative sepsis. Second is pneumonia. These are two important causes of ARDS. So now we have discussed about ARDS also. Now going on to question number 15. We have a 38-year-old female with cystic fibrosis received a double lung transplant. This is a little tough question. She had an episode of mild pulmonary allograft dysfunction post-op and has had 2 episodes of acute cellular rejection. I'll repeat, ACR stands for acute cellular rejection. That was successfully treated. She is currently on triple immunosuppression. So what do you mean triple immunosuppression? Generally, in any post-solid organ transplant situation, we use a corticosteroid. Okay, number one. Plus, we use anti-metabolite. What are anti-metabolites? We use either a mycophenolate mofetil or azathioprine. Any one of these drugs we are going to use. Plus, we are going to use a calcineurin inhibitor. So, which may be either a cyclosporin or a tacrolimus. Which means one steroid plus one anti-metabolite like MMF or AZA and one calcineurin inhibitor like cyclosporin, tacrolimus. Okay, so this is called triple immunosuppression. This is a common regime for most of the solid organ transplant patients. Currently, she has mild shortness of breath on exertion and her FEV1 has dropped from 85 to 65%, which means after lung transplant, being on immunosuppression, her FEV1 has dropped from 85. Lung function is declining, 85 to 65%. CT scan is apparently normal, which means okay, CT is fine. Which of the following findings is likely? Okay, so ball cultures positive for Aspergillus fumigatus, new moderate restriction on PFT, lymphocytic infiltrates surrounding arterioles on transbronchial biopsy, and new air trapping on expiratory CT without clear infiltrates. Remember, this is a completely Harrison based question. Because when the patient is on immunosuppression, first of all, remember, if it is an adequate immunosuppression, it's very unlikely to develop acute cellular rejection. So lymphocytic infiltrates surrounding arterioles and transbronchial biopsy is a finding of rejection, acute cellular rejection. I'll repeat, lymphocytic infiltrates surrounding arterioles and probably the bronchioles on transbronchial biopsy is a finding on, in a patient with acute cellular rejection. Okay, so that is not something that we are suspecting here, point number one. Because the CT chest is apparently normal. If it's a rejection, there will be some finding in the CT chest. And while on a good immunosuppressive regime, it's very unlikely to develop acute cellular rejection. A new moderate restriction on pulmonary function testing is also not correct because CT chest is normal. It should have showed some infiltrates or some ground glassing if it's a restrictive lung disease. So I'm not suspecting restriction. Ball cultures positive for Aspergillus fumigatus is also wrong because I'm not suspecting aspergillosis. Aspergillosis can occur in the early stages, but we are prepared for that. We are going to give antimicrobial prophylaxis with fluconazole for preventing aspergillus infections, especially invasive aspergillus infections. So I'm not going to expect that also. Right answer is new air trapping on expiratory CT without any clear infiltrates. The reason for that is there is one disease that is very, very important, often asked in exams with regards to lung transplantation, that is bronchiolitis obliterans. I'll repeat, that is called as bronchiolitis obliterans. So remember, bronchiolitis obliterans is a form of chronic rejection. So bronchiolitis obliterans will present in the PFT as obstructive lung disease, okay, as obstruction, where the patient will have low FEV1 by FVC, okay, low FEV1 by FVC, and the patient will have a low FEV1 without much change in the FVC. Because it's a bronchiolitis obliterans, CT chest will be apparently normal, and only when you take some special effort like doing an expiratory CT. Remember, generally we don't do an expiratory CT, we do only an inspiratory CT. So, but here if you are suspecting, you have to take a CT in expiration also, where you will see that the air is not going out properly. There will be air trapping in expiratory CT, without clear infiltrates. That is the finding that you see in patients with bronchiolitis obliterans. Very, very important complication in patients with lung transplantation. It's a form of chronic rejection. In fact, whatever I have given here is a risk factor for developing bronchiolitis obliterans. Like for example, Harrison clearly states that patients who are having primary allograft dysfunction is at risk of developing bronchiolitis obliterans, and patients who had a history of acute cellular rejection also is at risk of developing bronchiolitis obliterans, and patients with lung infections like Aspergillus infections are also at risk of developing bronchiolitis obliterans, honestly speaking. Okay, so whatever I have given here, primary allograft dysfunction, prior history of acute cellular rejection, or even if I have given history of infections like CMV infection or Aspergillus invasion, is also a risk factor for developing bronchiolitis obliterans. So in exam, how will you suspect bronchiolitis obliterans? Think about a post lung transplant individual, post lung transplant individual, or already or a patient who's having a rheumatoid arthritis. Even that's a very important point. Patients are having rheumatoid arthritis, following which they are presenting with shortness of breath, and if you do a pulmonary function test, ACR stands for acute cellular rejection. In spite of that, we get lymphocytes and biopsy specimen. What is acute cellular rejection? It is invasion of the transplanted organ by the native lymphocytes. That is rejection. So you will have lymphocytes. Okay. So PFT will show obstructive pattern. PFT will show obstructive pattern. So FE1 by FEC will be low, and here FE1 will be low. And in the CT scan, you will not see any much infiltrates plus a relatively normal CT, or I can say there will be expiratory air trapping. Expiratory air trapping. So this is a typical picture that you expect in exam as far as bronchiolitis obliterans is concerned. So post trunk transplant or a patient with rheumatoid arthritis presenting with shortness of breath, PFT obstructive pattern, CT no much infiltrates, but if they show expiratory air trapping, it is equivalent to bronchiolitis obliterans. It's a form of chronic rejection as far as lung transplanted individuals are concerned. It's very difficult to treat. So coming to 16th question. A 48-year-old man with a BMI of 32 has recently been diagnosed with OSA, that is obstructive sleep apnea, where the apnea-hypopnea index is 13. He does not have a history of snoring. He doesn't snore. He is unwilling for CPAP, which means he is not willing for CPAP, that is a continuous positive airway pressure, which is the gold standard treatment for any patient with OSA. Which of the following would be a possible alternative therapy? So is it bariatric surgery or supplemental oxygen or oral appliance or uvulopalatopharyngoplasty? What is the treatment? So first of all, you have to know that this patient is having a significant OSA. So OSA can be categorized based on, severity of OSA can be categorized based on your apnea-hypopnea index. If the apnea-hypopnea index is less than 5, it is considered to be normal. It is not OSA. It is not OSA in the first place. If the apnea-hypopnea index is 5 to 14, you can call it as mild OSA. If it is in the range of 15 to 29, we call it as moderate OSA. If it's more than or equal to 30, it is called as severe OSA. Severe OSA, okay? So our patient is having an apnea-hypopnea index of 13. So he's coming under mild OSA. But still, whatever may be the severity of OSA, the treatment of choice is going to be CPAP, that is continuous positive airway pressure. But here the patient is unwilling for CPAP. So the next step is to add an oral appliance. Okay. So oral devices are otherwise called as sometimes mandibular advancement devices. I'll repeat, mandibular advancement devices. So even that, that is the same thing only. So oral appliance is the second choice. The patient is unwilling for CPAP. But the first line, gold standard treatment is CPAP. And bariatric surgery, can you do? Yes, you can do bariatric surgery. But that is not the primary treatment of CPAP. Whether this patient is going to come under the inclusion criteria for bariatric surgery or not, answer is no. So what are the indications for bariatric surgery? So BMI more than or equal to 40, that is severe obesity or class 3 obesity, or alternatively BMI should be more than or equal to 35, plus patient should have some comorbid conditions, comorbids. Okay, these are the two indications. One, BMI more than or equal to 40 or BMI more than or equal to 35, plus patient should have some comorbid conditions like diabetes, hypertension, or even OSA, severe dyslipidemia. So something should be there. So then only you can do bariatric surgery. And there are 3 classic bariatric surgeries. Oral appliances are actually quite effective. Okay, somebody is asking about the efficacy. So, what are the 3 important surgeries that's been performed? I think the first one is LAGB, that is laparoscopic adjusted gastric banding. I'll repeat, laparoscopic adjusted gastric banding. Second is like called as vertical sleeve gastrectomy, that's called VSG. And the third one is RYGB, that is raw and Y gastric bypass. Raw and Y gastric bypass. So one is laparoscopic adjusted gastric banding, vertical sleeve gastrectomy, and raw and Y gastric bypass. So these are 3 surgeries. The most efficacious is raw and Y gastric bypass. The most reversible surgery, in the sense like you can completely reverse the surgery, the answer is going to be LAGB, that is laparoscopic adjusted gastric banding, but it's the most ineffective surgery also. LAGB is ineffective, but it's completely reversible. Raw and Y gastric bypass is most like effective, but it is not reversible. So, and it's a malabsorptive surgery also, so you need to supplement nutrition as well. So this patient is not eligible for bariatric surgery. Supplemental oxygen, no, I'm not going to use. If the patient is having probably central sleep apnea, so if the patient had central sleep apnea, then probably I would have considered supplemental oxygen. But here obstructive sleep apnea, there is no role for supplemental oxygen. So uvulopalatopharyngoplasty is also not a good option because the efficacy is less than 50%. Efficacy is less than 50%, and whatever may be the efficacy, it should be there only if the patient is having significant snoring. Only if the patient is having significant snoring, then UPAP can be tried. That is uvulopalatopharyngoplasty can be tried. Otherwise, we are not going to try uvulopalatopharyngoplasty. And the efficacy is also very, very poor. So our patient clearly does not have snoring, and I'm definitely not going to perform UPAP as a second choice also. Like it's like a last choice. And we have plenty of other techniques like lingual nerve stimulation and so on. I'm not going to talk about that right now. Coming to question number 17. Which patient below is most likely to have a breathing pattern as shown? So first you need to find out what is the breathing pattern. You need to look out what is the breathing pattern. So you can see there is a crescendo decrescendo pattern followed by a period of apnea. Which means there is initial hyperpnea, then hypopnea, then apnea, then again the same pattern is continuing. So yes, this is a Cheyne-Stokes respiration. This is a Cheyne-Stokes respiration. So which of the following patients are most likely to have Cheyne-Stokes respiration? A 6-year-old with poor school performance, snoring and enlarged tonsils and adenoids. A 48-year-old man evaluated for loud snoring, and EDS stands for excessive daytime sleepiness with a BMI of 36.8, obese. And a 52-year-old woman with BMI of 32 complaining of frequent nocturnal awakenings in the setting of menopause. And 68-year-old man with atrial fibrillation and ischemic cardiomyopathy with an EF of 15%. So remember, the first 2 cases are basically cases of obstructive sleep apnea, right? So here, I'm not going to expect a Cheyne-Stokes respiration. And third is a dummy choice. Here we are talking about a patient who is having a postmenopausal depression and very unlikely to have a Cheyne-Stokes respiration here as well. The right answer for this question is option D. In fact, the most common cause of Cheyne-Stokes respiration in practice is heart failure. Remember, heart failure is the single most important cause, or I can say the most common cause of Cheyne-Stokes respiration. Heart failure, single most important cause and the most common cause of Cheyne-Stokes respiration in practice. That is because of delay in the circulation time. In heart failure, the blood flow will be sluggish and the brain will take time to respond to changes in the PaCO2. And that is because of the delay in the circulation time. So that's the reason why heart failure is the most common cause of Cheyne-Stokes breathing. So going to the next question. We have only, I think, 3 to 4 questions left. So don't worry, it's going to end soon. So 18th question, a patient was diagnosed with empyema for which a chest drain was placed, which means patient was diagnosed with the empyema. Which of the following treatments can be recommended in this patient to improve the resolution of empyema in this individual? So for empyema, they have already placed a chest drain. So what additional treatment you can give? This is a completely Harrison-based question again. So option A is immediate referral for decortication. Option B is intrapleural installation of alteplase and DNase. Option C will be intrapleural installation of streptokinase, and option D will be intrapleural installation of talc and bleomycin. So what is the right answer? The right answer for this question is option B, intrapleural installation of alteplase and DNase, straight lines from Harrison, nothing more than that. It's an exact line that is given in Harrison. One of the best treatment is going to be intrapleural installation of alteplase and DNase, because in empyema there will be adhesions and that has to be broken down. That's why we use this. So another parallel information that you need to learn is what are the indications of chest drain in a patient with pleural effusion or in a parapneumonic effusion. Number one, remember, pneumonia patients will develop something called as parapneumonic effusion. Parapneumonic effusion. So what do you mean by parapneumonic effusion? So if you have a pneumonia and if that pneumonia is causing a reactive effusion, that's called as parapneumonic effusion. So this parapneumonic effusion can become complicated. So what do you mean by complicated parapneumonic effusion? Complicated means once the organism starts invading the pleural space, you have a consolidation and a pneumonia, and from that area if the organism starts invading the pleural space, that's where we're going to call it as complicated parapneumonic effusion. So what are the signs of complicated parapneumonic effusion? Number one, pH less than 7.2. Remember, the normal pleural fluid pH is 7.6 alkaline. If it's less than 7.2 acidic, it is complicated. Number two, patients who are having frank pus, which means empyema. While aspirating, if you have frank pus, empyema, that's complicated. It's a pus in the pleural space. Number three, if gram stain or some culture of the pleural fluid is positive, the gram stain or culture of the pleural fluid is showing some organisms, okay, that is also a sign that the bacteria is invading the pleural space. That also means that the patient is having a complicated, okay, parapneumonic effusion. And how you treat? The treatment of choice in complicated parapneumonic effusion, not just antibiotics, you have to insert a chest drain. So the moment you know it's a complicated parapneumonic effusion, you need to insert a chest drain. And number four, fourth point is very low glucose less than 60. Okay, even this is a sign of complicated parapneumonic effusion, organisms invading the pleural space. So the treatment of choice for any complicated parapneumonic effusion is going to be chest drain. But in case if you are dealing with empyema or a kind of effusion with so much of septations, okay, you can also try alteplase and DNase installation into the pleural space so that to break the septations and you can treat the empyema faster. That's the idea. Coming to question number 19, I think if you have listened to the previous question and its explanation, this becomes so easier. Indication of chest drain in a parapneumonic effusion are all except. What is the right answer? Indications of chest drain in a patient with parapneumonic effusion are all except. Okay. Okay, so let me tell you the answer. Answer is pleural fluid LDH more than 1000. So I'll tell you why I framed this question specifically. So remember, lock-related effusion definitely are going to insert the chest drain. So probably you can add actually. So if you want to know, it's like lock-related effusion also. In lock-related effusions also you need a chest drain. Not because it's complicated. Any lock-related effusion is very difficult to treat without a chest drain. That's an indication for chest drain. And pleural fluid pH less than 7.2 is a definite indication for inserting a chest drain in the setting of parapneumonic effusion because it indicates the complicated parapneumonic effusion. And pleural fluid glucose of less than 60 is also very important straightforward indication of chest drain because it also tells you that the patient is having a complicated parapneumonic effusion. Okay, pleural fluid LDH more than 1000 is not a definitive indication for chest drain in the setting of parapneumonic effusion because in the old guidelines, okay, if you look at the American Thoracic Society guidelines before 2012 or if you look at 18th edition of Harrison, probably they are given this as an indication. Okay, pleural fluid LDH more than 1000, but this has been removed in the current recommendations and even Harrison doesn't mention this anymore. So that's why I have specifically mentioned this. Okay, the right answer for this question is going to be option D. Coming to question number 20. Okay, we have only 2 more questions. So here you have a 62-year-old smoker who's presenting with shortness of breath on exertion. Resting SpO2 is 94%, but on walking to 100 meters, the SpO2 reduces to 85%. Examination reveals bilateral end inspiratory crackles. The CT chest, I don't know why the images are not appearing here. Sorry for that. Unfortunately, some images are missing. But I will say that CT chest is showing basal reticular densities, okay, reticular appearance with fibrosis and honeycombing, and it's bilateral. honeycombing. Honeycombing is seen with reticulations and fibrosis in the basal areas. Okay, and serologic workup for autoimmune disease is unremarkable. That is negative. What is the next best therapeutic option? So remember a 62-year-old patient, okay, who is having desaturation on exercise. So whenever there is exercise desaturation, okay, exercise desaturation, in exam you need to think about only two things. One is emphysema, very important point, emphysema. Second is ILD. So these are the only two things that's going to cause desaturation on exercise. Okay, and I told you the findings are not consistent with emphysema. The patient is having basal, bilateral, reticular densities with fibrosis and honeycombing plus or minus traction bronchiectasis, and you are suspecting a UIP, usual interstitial pneumonia, but my autoimmune workup is negative. Okay, I'm not having any autoimmune disease. Rheumatoid factor is negative. So I'm thinking about a idiopathic UIP, idiopathic usual interstitial pneumonia, which is nothing but IPF, that is idiopathic pulmonary fibrosis. So how idiopathic pulmonary fibrosis will present? Number one, elderly patients. It has no association with smoking. Number one, whether the patient is a smoker or not, it doesn't matter. No association with smoking so far, but it's controversial. Age more than 50. Patient will present with a chronic course. It will be months to years together, where the patient will present with shortness of breath and dry cough. Shortness of breath and dry cough. Plus or minus, patients can have clubbing, cyanosis and all depending on the duration of illness. And patients will have exercise desaturation because it's a classic ILD. That's another important point, exercise desaturation. Any interstitial problem will cause exercise desaturation. In PFT, you are going to see intrinsic RLD pattern. Intrinsic RLD pattern. So what do you mean intrinsic RLD? FE1 by FEC will be normal, more than 70%. FEC will be low, less than 80%, and DLCO also will be low. Okay, that is intrinsic RLD pattern. That's what is going to occur. And in CT chest, I told you the classic picture already. I'm not going to write again. Most of the times, HRCT itself is going to tell you the diagnosis. Bibasal, okay, subpleural, reticular densities with fibrosis and macrocystic honeycombing plus or minus traction bronchiectasis. This is the typical picture. And you will not see much of GGOs. If you see more of ground glass opacities, that is not IPF. Should not see much of ground glass opacity. This is not a feature of IPF. Okay, this is the typical CT picture. Okay, and on examination, you will hear something called as fine end inspiratory Velcro crackles. Velcro crackles. Fine end inspiratory Velcro crackles. Okay, that's what I'm going to find in examination. Fine end inspiratory Velcro kind of crackles. These are dry crackles. That's what we're going to see. This is a typical examination finding. And most importantly, you need to rule out autoimmune disorders because many autoimmune disorders, including rheumatoid arthritis, can produce a UIP-like picture. So it's important to rule out autoimmune disorders. Once you have ruled out autoimmune disorders, with the picture that I have told in the slide, that becomes an IPF, that is idiopathic pulmonary fibrosis. That's all. So remember, corticosteroids are not indicated in IPF. You know very well in Guillain-Barré syndrome, that's a common question in exam, corticosteroids are not indicated. But similarly, in patients with IPF also, corticosteroids are not indicated because it's not shown to be effective. See, there are 2-3 things in exam where you don't answer corticosteroids at all. Number 1, Guillain-Barré syndrome, AADP. Number 2, IPF. Number 3, anyone wants to say? It's going to be scleroderma. You can use, but high-dose steroids are contraindicated. People are going to answer why later on. Why high-dose corticosteroids in scleroderma is contraindicated and should not be used and it should be avoided. Because it's going to increase the risk of scleroderma renal crisis. So 3 conditions where you don't use corticosteroids. In exam, answer scleroderma, IPF, GPS, no steroids. So what are you going to use? Nintedanib. Nintedanib is what you're going to use. So there are 2 options that are available. These are anti-fibrotic therapies. So what are the anti-fibrotic therapies? One is Nintedanib, which is a tyrosine kinase inhibitor, and second one is going to be pirfenidone. Pirfenidone, which is a TGF-beta inhibitor. Both are basically anti-fibrotic therapies. Okay, so treatment of choice. So fine, so IPF is done. It's a very important ILD for your exams. Okay, now finally, last question, bonus. Okay, this is based on environmental medicine. A soldier operating in Siachen Glacier presents with numbness of his legs. Incorrect regarding the image given. So what is not correct regarding the image? So look at this. This is the image that's mentioned in one of the INA CT exams. You can see that the patient is presenting with numbness in his legs, and with this picture, what you are suspecting and what should be the right answer for this. So they are asking which of the following is not correct, incorrect. Rewarming is the treatment of choice. Analgesics are contraindicated. Thrombolytics can be used. Amputation in severe cases. So what is the right answer? So basically you are dealing with something called as frostbite. So remember, frostbite is an example of freezing injury. It's a very important question in many exams. Freezing injury. So most of the patients, presentation will be with numbness only. Numbness. So in the affected areas, it's going to feel very numb because of the formation of ice crystals, no sensation. Most of the patients will complain that as if they are feeling the hands or legs like a wooden block. No feeling, numbness. And in the early stages, the signs will be very, very less. Patient may feel just numbness, nothing more than that. But there won't be any signs. Here at least you're seeing erythema. But sometimes there may not be any sign at all. Patient can have a completely normal hand. Just they will say numbness, that's all. It needs a very high degree of suspicion. You have to be very careful. Because if you send the patient home thinking that there is no local signs, then the hand will be lost or leg will be lost. You have to be very careful. Okay, don't expect a lot of signs, just numbness. You have to have a high degree of suspicion. And you touch the hand, it will be very, very cold. And the moment if they say numbness and the hand is very cold, even if you don't see much signs, think about frostbite. So immediately what you're going to do is you're going to rewarm. So rewarming is the next step. So remember, rewarming can be excruciatingly painful. It's one of the most painful conditions that you can ever encounter. So and what will be the temperature of the water? The temperature of the water is going to be somewhere around 37 to 39 degrees Celsius, or you can say 37 to 40 degrees Celsius. That will be the temperature of the water that you should use for rewarming. But in case if the patient tells severe pain, okay, then you can use a water with a temperature of 35 to 37 degrees Celsius also, but that's only when the patient is complaining of severe pain during rewarming. Otherwise, you can use a routine temperature of 37 to 40 degrees Celsius while rewarming. And remember, analgesics are very, very important. But don't use NSAIDs. Don't use NSAIDs. Okay? Use opioid analgesics. Okay? Analgesics are very, very important because it's a very painful condition. And apart from that, later on, once you have initially rewarmed the limb, the next step is going to be to do some imaging. You have to do imaging. Okay? In case if the patient is presenting within 24 hours, I'll tell you why. So the most important imaging that we do, commonly what we use is MR angiogram. So in MR angiogram, depending on the occlusion of the vessels, if the patient is within 24 hours, and if the MR angiogram shows some occlusion of vessels, you can use thrombolytic agents. Typically, we use RTPA. Okay, RTPA. RTPA can be used. Thrombolysis can be used if it's within less than 24 hours. If the patient is presenting beyond 24 hours, then there's no point in doing MRA. Rather, we can use something called as bone scans. Okay, we can use something called as bone scans. So why not NSAIDs? Because NSAIDs are going to stop prostaglandins. Already this patient is having vasoconstriction because of cold and there's occlusion of vessels. Why you want to use NSAIDs and cause reduced prostacyclin synthesis and cause more vasoconstriction? Okay, everyone knows that even in Prince metal angina, you don't use NSAIDs or carefully use NSAIDs like aspirin because of additional risk of vasoconstriction. That's why we don't use it as much as possible. So more than 24 hours, the patient is presenting more than 24 hours, you need to do bone scans to find out the extent of amputation. So decide the extent of amputation, we need to use bone scans because bone scans is going to tell you, or even some people use FDG PET also, but traditionally we use bone scans to find out what is the extent of devitalized tissue, how much tissue has been lost. Based on that, we can amputate the limb. So that will tell you how much to amputate also. Okay, so that's the idea. So Option A, rewarming is the treatment of choice. That's absolutely correct. Thrombolytics can be used. Yes, in selected patients, you can use thrombolytic agents. Amputation in severe cases, even that is right. Before using thrombolytic agents, you have to use MR angiogram. If it's presenting within 24 hours, you can use thrombolytic agents. After 24 hours, depending on the bone scans, you can do amputation also, because it will tell you what is the amount of devitalized tissue. Analgesia contraindicated is a wrong statement, and that becomes the right answer because we wanted to know what is incorrect. In fact, analgesics are indicated. The right analgesic you should choose because it's a very, very painful condition. And there are another bonus point. There are some other bonus points which I want to say. One is how will you treat high altitude pulmonary edema, because this is also a high altitude related problem. And second is high altitude cerebral edema. How will you treat? For both these conditions, you have to definitely use oxygen. Okay. You have to definitely use some pressurizing chambers. Temporary pressure chambers can be used. Okay, temporary pressurizing chambers where it's like a balloon-like device where you can place the patient inside and you can pump air, like how you do with a cycle pump. Okay, you can pump air and you can increase the pressure in the chamber and you can carry the person in that pressure chamber. Okay, there are many commercial names, but these are called as temporary pressure chambers, which will mimic as if the patient is at a lower altitude. And all patients can be given dexamethasone, no problem. So this is a standard treatment for any high altitude emergency. Okay, but for pulmonary edema, additionally you can consider NIV, CPAP additionally, and additionally you can consider nifedipine also. Additionally. Okay, some people are answering astazolamide. Remember, astazolamide is not going to be helpful in emergencies. For simple conditions like acute mountain sickness, astazolamide may be helpful. That too as a prophylaxis. To prevent minor problems like acute mountain sickness, you can use astazolamide as a prophylaxis. But astazolamide is neither the treatment nor going to work as prophylaxis for severe problems like high altitude pulmonary edema and high altitude cerebral edema. Some people are asking why dexamethasone, because it's a vasogenic edema. Cerebral edema is also vasogenic, pulmonary edema is also vasogenic. For any vasogenic edema, corticosteroids, especially dexamethasone, is going to be the treatment of choice. So oxygen, pressure chambers, dexamethasone for all. But if they ask you the treatment of choice, these are only temporary measures, but the treatment of choice is going to be immediate descent. Immediate descent. Okay. Yes, it's still live. So immediate descent. Okay, treatment of choice is immediate descent, rapid descent. But temporarily you can use these options: oxygen, pressure chambers, dexamethasone. For high altitude pulmonary edema, you can additionally use NIV plus or minus nifedipine. But the treatment of choice is immediate descent only. So as I told you already, acetazolamide is not going to work as prophylaxis for or even treatment for acute high altitude pulmonary edema and high altitude cerebral edema. Acetazolamide doesn't work. Whether you give acetazolamide or not, severe illness like HAP and HSE and its incidence cannot be reduced. Okay, so that's done. Okay, so we have discussed the most important things as far as your pulmonary medicine and critical care is concerned. In fact, some of the emergency medicine topics also I have discussed, and I have discussed a little bit of your environmental problems also, like frostbite and high altitude related illness, which is very commonly asked in exams in the recent past. So I hope you enjoyed this academic feast and this starting medical session with regards to your medicine Saturdays, and hope everyone will be keeping on attending the medicine Saturdays and the BTS by Dr. Zainab regularly to get benefited, and wish you all the very best for your exams. And I think we have another class again at Jan 14. Okay, see you there. Thank you very much.